Welcome back to the Score Builders Question and Answer podcast. This podcast provides members of the Score Builders team with the opportunity to explore challenging multiple choice examination questions with students actively preparing for the licensing examination. Ready? Let's go. A patient recently diagnosed with Cushing syndrome is referred to physical therapy for generalized deconditioning. Which clinical finding would most likely be observed during the physical therapy examination? Option 1, distal muscle atrophy and hyporeflexia in the lower extremities. Option 2, hypotension and resting bradycardia. Option 3, proximal muscle weakness and thin, easily bruised skin. Option 4, spastic paraparesis and bilateral clonus at the ankles. Cushing syndrome results from prolonged exposure to elevated cortisol levels, whether from endogenous overproduction or exogenous corticosteroid administration. The clinical presentation reflects widespread catabolic and metabolic effects of cortisol excess across the musculoskeletal, integumentary, and cardiovascular systems. Before we look at the options, let's build a clear picture of what cortisol excess actually does to the body. When cortisol is chronically elevated, its catabolic effects become destructive across multiple body systems. In the musculoskeletal system, cortisol suppresses protein synthesis. In excess, this can lead to muscle wasting, pronounced in the proximal muscle groups. In the integumentary system, cortisol inhibits collagen production. Without adequate collagen, the skin becomes thin and prone to bruising. In the cardiovascular system, it promotes sodium and water retention, which drives up blood pressure. Keep these three systems and their cortisol-driven changes in mind as we evaluate each option. Let's explore each of the options. Option 1, distal muscle atrophy and hyporeflexia in the lower extremities. Distal muscle atrophy and hyporeflexia are hallmark findings of peripheral neuropathy or lower motor neuron disorders. Cushing syndrome tends to affect proximal musculature more than distal musculature. Additionally, while Cushing syndrome can sometimes result in abnormal reflexes, this is not a defining clinical feature of the condition. The pattern of muscle involvement is the key to eliminating this option. Cortisol's catabolic effect on muscle protein synthesis preferentially affects the large proximal muscle groups, the hip flexors, hip abductors, and shoulder girdle muscles. This option describes the wrong distribution and the wrong neurological pattern. Option 2, hypotension and resting bradycardia. Hypertension, not hypotension, is a characteristic cardiovascular finding in Cushing syndrome, driven by cortisol's mineralocorticoid-like activity, which promotes sodium and water retention. Resting bradycardia is not associated with this condition. This option gets the cardiovascular findings exactly backwards. Cortisol promotes sodium retention, which draws water into the vascular space, increasing blood volume and driving up blood pressure. If you remember that cortisol excess means sodium retention, which means fluid retention, which means elevated blood pressure, this option becomes easy to eliminate. Option 3, proximal muscle weakness and thin, easily bruised skin. Cushing syndrome is characterized by proximal muscle weakness, which is caused by cortisol's catabolic suppression of skeletal muscle protein synthesis. Thin, easily bruised skin results from cortisol's inhibition of collagen production. Without adequate collagen, the skin loses its structural integrity and becomes fragile, leading to easy bruising, ecchymosis, and the characteristic purple striae that are a hallmark of Cushing's syndrome. Both findings described in this option are direct, mechanistically explained consequences of chronic cortisol excess. Two findings. One unified mechanism. Cortisol excess acting catabolically on both muscle and connective tissue. Option 4. Spastic paraparesis and bilateral clonus at the ankles. Spastic paraparesis and clonus are upper motor neuron signs associated with spinal cord injury or corticospinal tract lesions. These findings are not produced by cortisol excess and are not characteristic of Cushing syndrome. This option describes a completely different pathological process. Cortisol excess does not damage the corticospinal tract and does not produce upper motor neuron signs. This option can be eliminated quickly because it describes neurological findings that have no mechanistic connection to Cushing syndrome whatsoever. When we apply our cortisol excess framework across all four options along the way, only option 3 describes findings that are direct, mechanistically explained consequences of chronic cortisol elevation, proximal muscle weakness from catabolic suppression of protein synthesis, and thin, fragile skin from inhibition of collagen production. The correct answer is option 3. Let's explore the all-student data. 49% of students selected option 3, proximal muscle weakness, and thin, easily bruised skin, the correct response. 25% of students selected option 2, hypotension and resting bradycardia. 23% of students selected option 1, the distal muscle atrophy and hyporeflexia in the lower extremities. 3% of students selected option 4, spastic paraparesis and bilateral clonus at the ankles. This question is an other systems question which represents approximately 18% of all exam items. This question is a foundations for evaluation, differential diagnosis, and prognosis question which represents approximately 10% of all exam items. This question is a level 1 question since the question requires students to possess basic foundational academic knowledge. Remediation of level 1 questions occurs through academic review of entry-level content using textbooks, review books, Basecamp, and flashcards. Looking to review related academic content? Check out page 539 and 657 in PT Exam, the complete study guide. Thanks for joining us on the Score Builders Q&A podcast. See you next week.